I'd like to introduce our next speaker, Professor Henry Brodaty. He's a local from the University of Sydney, a Scientia professor at the Aging and Mental Health Department. He's a director of Dementia and Collaborative Research Centre and a co-director of the Centre of Healthy Brain Aging, short as SHEBA. And he's also the president of the International Psychogeriatric Association. We're very excited that he takes the time out of his busy schedule to give a talk. And he will talk to us about physical comorbidity of dementia.
Thank you very much, and thanks for the opportunity to speak to you. So, as you heard, I work mainly in the area of dementia, or mental health of older people generally. And I work at the University of New South Wales, and both in the Dementia Collaborative Research Centre. And a copy of this talk will be posted on our website, so you can obtain it from there. I'll give you the web address at the end. And also the Centre of Healthy Brain Aging. And the talk is based on a book which was written basically by Sue Curl. I'm one of the co-authors of it, but Sue did the bulk of the work, and I'll give you the address for that too. So, what is physical comorbidity? It's a condition or disease that coexists with another disease and has a possible pathological link to that disease and occurs more often in that disease. In dementia, we know that people lose their memory, lose other cognitive functions, they decline, their IADLs and ADLs decline, and they get behavioural disturbance. What we don't really put much emphasis on is the physical comorbidity. And what happened is the WHO contacted me and wanted me to write a book on physical comorbidity of dementia, and really wasn't what I had expertise or the time to do. And I spoke with Sue Curl, and she took up the cudgel and wrote this magnificent little book which summarises it, and that's what I'm going to summarise in this talk, which is based on one that Sue sent me. So what Sue and Roseanne Hogarth did is reviewed almost 4,000 articles, and they selected the following comorbidities for reviewing: falls, which is what you're interested in, but also other things that you don't think about in dementia: epilepsy, delirium, frailty, malnutrition, oral disease, visual impairment, sleep disorders, and incontinence. We did not review pain or behavioural and psychological symptoms of dementia. That's a whole different area. So here's an example. Mrs. K is a 74-year-old lady who lives with her husband in their own home. She has a 7-year history of Alzheimer's disease. She's on Donepezil or Aricept, and now significantly cognitively impaired. She needs prompting or assistance with most ADLs. 4 years ago, she started experiencing visual problems. She had difficulty seeing and negotiating steps. She had occasional trips and sometimes falls. She was often unable to locate the knife or fork on the table when eating. She started losing weight about 3 years ago, despite eating well, and has now lost 7 kilos. A year ago, she developed urinary incontinence. She uses a pad. Her husband tries to obviate this by regularly toileting her. 8 months ago, she developed an episode where she developed twitching of her right leg, which then gave way, and that led to falls as well, which was followed by a period of confusion or delirium. 2 months ago, a fall resulted in a hip fracture. She had a hip replacement, and she's now in high care. This is not an uncommon scenario, and you can see the multiple comorbidities coming into play during the course of this woman's dementia. So let me start with falls. The annual incidence of falls in the cognitively impaired population is much higher. It's double the rest of the population at about 70 to 80%. Fractures are 3 times more common in people with dementia. People with dementia are more likely to die in the first 6 months after their fall and fracture. Some sorts of dementia are particularly associated with gait difficulties: vascular dementia, dementia with Lewy bodies because they get the bradykinesia and the Parkinson-type features, and Parkinson's disease dementia. People with dementia are often on psychotropic drugs. Over 50% of people in nursing homes are on psychotropic drugs. Almost 30% are on antipsychotics. any of these drugs increase the risk of falls. Many of them are associated with orthostatic hypertension, so their blood pressure drops to their ankles when they stand up, and that makes them more likely to fall, and particularly with the Parkinson plus syndromes. And postural instability is more common in dementia. Other reasons why people with dementia fall is they have poor executive function. They don't plan, they don't think ahead, they don't anticipate. Their motor planning skills, their motor function's okay, but their motor planning skills are poor. They have unrealistic perceptions of their motor abilities, reduced attention span, impaired visuospatial skills. They're impulsive, they have frontal lobe impairment, they're more likely to be impulsive and take risks. There is no particular intervention proven to prevent falls in people with dementia. There are many things we do. We put on hip protectors, we make sure they're on soft surfaces, we attend to the lighting, we look at their shoes. Putting people in restraints increases the risk for falls. And we can screen, and we do fall risks assessments, but that's not proven very successful in planning interventions. So recommendations: review medications and try and de-prescribe antipsychotics and all psychotropics like benzos. Assess and treat orthostatic hypertension or postural hypertension. Treat cataracts. Simple strength and balance training exercises, and there's a program being led by Jackie Close, I don't know if she's in the audience, doing just this. Environmental modifications, the linings, the floor coverings, the lighting, rails, fall alarms, hip protectors, helmets even, and vitamin D. I'll come back to vitamin D, particularly if low bone mineral density. So, good shoes on, bad shoes on your left, better shoes in the middle, not as fashionable, and scatter rugs are definitely a no. Okay. Our chair has done, and I'm going to quote some research that we've been doing from our memory and ageing study in collaboration with the Falls group led by Stephen Lord, Kim Delbert, Jasmine and Dana. There's a whole bunch of them we've been very pleased to cooperate with in the last few years. So I sent you an email, Kim, which you've probably been too busy at the conference to look at, saying, is it okay to quote your work? Okay. So what Kim did was to look at people who are and their risk of falls and looking at their profiles. And she classified them into two groups, four groups, but the two I'm concentrated on: people who are anxious, had a high fear related to depressive symptoms, neurotic personality, and decreased executive function. And just being anxious about falling is a risk factor for falling, apart from everything else. And then the Stoics, who are low risk, this was protective for falling, they had a positive outlook on life, and they maintained physical activity and community participation. The disparity between the perceived risk of fall and the actual risk of fall was primarily associated with psychological measures and also strongly influenced the probability of falling. So just being frightened of it makes people more tentative and makes them more at risk. In another study, which is of over 400 people from our epidemiological cohort of over 1,000 people, we've been following up the Sydney Memory and Ageing Study, there were 419 who had a neuropsychological assessment and had 80% were normal, and almost 15% had non-amnestic mild cognitive impairment, and 4.5% amnestic mild cognitive impairment. Mild cognitive impairment, or MCI, is an intermediate stage between normal and dementia, where people have some cognitive impairment, subjectively and objectively, but are functioning pretty well normally. And what Kim and colleagues showed for the first time, there was an increased risk of falling in MCI independent of the other usual factors. And this was particularly the case with non-amnestic mild cognitive impairment. So the problems in cognition that they complained about, or we found on testing, was not about memory, but particularly about executive function, planning, organisation. And so the conclusions were that MCI is an independent risk factor for injurious or multiple falls in community-dwelling older people. These are people we chose from the population, from the electoral roll, who didn't have dementia as part of our entry criterion. And the relationship between falls and MCI was mainly explained by this poor executive function. Many of you will do the mini-mental state to test cognition. which basically ignores executive function. So you won't pick up poor executive function if you just do a MIDI mental state. At least do the clock drawing test as well. And in another study, we looked at white matter lesions and fall. So about 550 of our 1,000 people cohort have had MRIs, and many of them serial MRIs. And people had more white matter lesions in their brain, generally reflecting vascular damage, were associated with poorer performance in executive function and a higher physiological fall risk assessment. If they were in the top quartile for white matter lesions, they had a threefold increased risk of falls, independent of other covariates. I'm going to skip this, okay. And then the final paper I want to tell you about is Tasha Kveld's work, and this was for her PhD, where she looked at depression and the risk of falls. And here we see that there are three risk factors: the physiological fall profile, and performance on the trail making test B, which is a test of executive function, which we just heard about, and depression, a score above 5 on the geriatric depression scale. And each of these increase the risk. And if you had all three factors, you see the risk is increased by 70%. Let me turn now to vitamin D. Vitamin D deficient adults have an increased risk of dementia. In this study of 1,500 plus people aged 65 or more, followed up for 6 years, 171 of them developed dementia, of which 102 had Alzheimer's. And those with low vitamin D levels were twice as likely to develop dementia and Alzheimer's disease. There was an association between vitamin D level and cognition and Alzheimer risk. Now, we're all aware of the risk for vitamin D on bones and the falls independently of that. So Yasmin Manant, who's from the same group, found there was a 30% prevalence of vitamin D insufficiency in our group. And there was a small association with cognitive function, particularly executive function, visuospatial domain, important domains for falls. And it was strongly related, the low vitamin D, with poor neuromuscular function and balance. So vitamin D increases the risk of injurious and multiple falls for men and women, with vitamin D insufficiency. And vitamin D insufficiency is associated with impairments in physiological and cognitive functions that predispose older people to fall. Now, the vitamin D's got a lot of functions in the brain, not just with bones. It's in the hippocampus. It regulates the expression of various neurotrophins, enhances survival of brain cells, can help clear the brain cells of amyloid. And in Australia, more than half of Australians are vitamin D deficient. In nursing homes, almost everyone is vitamin D deficient. Now, we don't know if taking vitamin D improves cognition, but it may have a major role here in falls. Okay, let me leave falls and talk about the other comorbidities in less detail. Epilepsy. The seizure incidence in people with Alzheimer's and vascular is higher than you expect in the general population. And vascular more. Both generalised and partial seizures are seen. And we see many case reports such as amnestic wandering, transient epileptic amnesia, unexplained falls. So when somebody is falling, that's something in a differential diagnosis, particularly often they're unwitnessed, which makes it difficult. 5 to 10% of people with dementia will have an epileptic seizure during the course of their dementia. It's 6 times higher rate of seizures in people with dementia versus the normal older population. And for younger people with dementia, or younger people in general, those with dementia have a much higher rate. You'll see this 87 times higher versus others, people aged 50 to 59. And for people aged 85 plus, it's 3 times higher. We know that people with Down syndrome all get Alzheimer changes in their brains by their 30s, 40s, and many of them get the clinical syndrome. They also have a higher rate of seizures. So, recommendations. Be aware that seizures are more common in people with dementia, and they may be atypical. The EEG may not be conclusive, often isn't. We treat Alzheimer's with cholinesterase inhibitors like Aricept or Reminol or Exelon, and these increase the risk of seizures. This is in their product information. And so treatment with anti-epileptics may be warranted, but of course then there's the evidence of increased risk of falls. Let me turn to malnutrition. In one of Alzheimer's original patients, Alzheimer was a neuropathologist from Germany who described his patient in 1906. He just said that Alzheimer patients were likely to lose weight. And in fact, it's been shown they lose over 5 kilograms during the course of their disease. And it may be that they become less efficient at regulating their metabolism. And so there's dysregulation and can lose up to 10% of body weight. A few gain body weight. People with vascular dementia, as well as Alzheimer's, and people with frontotemporal dementia also lose weight. Sometimes the weight loss can be a prodromal feature of Alzheimer's, and in several cohort studies with up to 25 years follow-up, when weight started falling off, dementia came on later. And dementia increases the risk of malnutrition. That was in a Finnish study. It was double-fold. So when people become malnourished, their muscle bulk shrinks, they get sarcopenia, they're more likely to fall. Recommendations. Identify patients at risk of weight loss and protein energy malnutrition, and try to prevent loss of muscle mass and strength, pressure ulcers, loss of immunity, and increased infection. How do we do that? Oops. Intervene where the weight loss is more than 5% in the last few months. Educate the family and professional carers. Enteral feeding, putting a tube down or a tube through the stomach is not recommended. And there are some dietary strategies. Giving oral supplements a couple of hours before the meal, like such as Ensure, use of finger foods, favourite foods, having a home-like environment, not an institutional environment. Having tablecloths, some people put music on, have fish tanks in the dining rooms. Have a contrast of the plate versus the table mat. Make it very eye-catching with the food. And regular exercise can stimulate appetite and prevent dehydration. All right, let me turn now to frailty. Frailty has been defined a number of ways. The two big definitions are from Rockwood and Freed. Rockwood said it was a multidimensional syndrome with loss of reserves in physical ability, cognitive health, which leads to increased vulnerability. Freed operationalised this. Weight loss, low grip strength, self-reported exhaustion, slow walking speed, and low physical activity. Now, a lot of these are also risk factors for dementia. So when people start losing weight, when they reduce their activities, when their gait slows, it may be vascular or Parkinson-type gait. And cognitive impairment also contributes to frailty. It's associated with decrease in strength and walking speed, and this may antedate the Alzheimer's by many years. And we do the test, where you get someone to walk and talk simultaneously. And as people lose their cognitive abilities, they can walk and they can talk, they can't do them both together. And that's quite a sensitive test. In the Rush aging study of more than 800 people, Alzheimer's developed more in the frail compared to the non-frail over several years follow-up. Another indicator is grip strength, and that is associated with poor cognition in many studies. It's a general sign of frailty. So recommendations, exercises, and I could give you a whole talk about prevention and physical exercise as being a preventative for cognitive decline, but a couple of studies have now come out showing hippocampal size increases in older people with MCI who are exercisers versus the control group. It may slow cognitive decline, and it may lower some of the chemicals that are bad in the brain, such as the interleukins and tissue necrosis factor. Address nutritional requirements and psychological factors. The strongest risk factor for delirium is dementia. Most people with dementia, if they have an insult, it could be a UTI, it could be a fall, it could be a change in medication, they're on the precipice and anything can tip them over and they can develop an acute confusional state, which is the delirium. So the presence of dementia increases the risk fivefold. 2/3 of cases of delirium occur in people with dementia. But Jackie Close has been leading a study which has really demonstrated quite clearly that most cases of delirium are not recognised. Usually dementia is blamed, But dementia people are going down steadily. If they have a stepwise decline, think, is there delirium on top of the dementia? In New South Wales hospital patients, the CHOPS project that Jackie led, between half and 80% of people with delirium were not recognised, were not diagnosed. The more severe the dementia, the greater the severity of the delirium. And it can be multiple causes. It can be an acute medical illness, it can be medications, it can be alcohol, it can be pain, it can be hypoxia, it can be post-operative. I'm going to skip this because we're going to run out of time. So the recommendations: expect delirium in unwell and hospitalised older patients with dementia. Assess regularly. The one that's used is the confusion assessment method, or the CAM. Treat the underlying cause, but also keep the person well hydrated, orientated, lights. Be aware this person now is at a much higher risk of other complications. There needs to be a systematic process for identifying patients at risk for delirium. This requires staff training, keeping people in a stable environment. Patients in hospitals can be moved several times within a few days, from ward to ward, bed to bed, and if you're not disorientated when you start, you certainly would be after the third move. Appropriate ward accommodation. Wards that are set up for older people do much better than putting in haphazard wards because there's a bed available. Avoid use of psychotropics, educating staff and family, avoid anticholinergic medications and physical restraints. Okay, let me turn now to oral disease. So, here I am talking about a Falls conference about oral disease, but oral disease really makes a big difference. And here you'll see some dirty pictures. So people on many drugs get dry mouth. People who are older in general, their mouths dry up, xerostomia. And what that leads to is bacterial growth and gum and teeth decay. And without protection of salivary enzymes and basic dental care, it only takes a few weeks. And you can see someone coming to a nursing home and their oral health will have declined. And here are some more pictures of these are people in nursing homes and what they're living with. And of course, when your teeth look like the top left-hand corner, you don't smile, you lose your confidence. Oral health is bad for self-esteem. Oral ill health is bad for self-esteem and also for nutrition, and of course, all consequences. Then inflammatory process and infections step in, and there's a lot of complications that flow. So older people with dementia have plaque accumulation, caries, fewer natural teeth, dry mouth, a big problem. They use their dentures less often. Often they lose their dentures. Dentures you can find in somebody else's little bowl by their bed, your dentures. Now you can label the dentures. Some of the oral health problems start occurring before dementia is diagnosed. In my routine clinical practice, one of the questions I always ask the family carers, are they washing, are they dressing, are they cleaning their teeth? And carers forget to monitor this. It's really important. And chronic inflammation has been linked to poor cognition as well. So why does this happen? Well, there's poor ability to manage their own care, inability to follow instructions. They're not motivated. They don't have the planning, executive function. They may have dyspraxia or agnosia, so particularly visual agnosia I'll come to. Decreased ability to adapt to changes such as dental plate or dentures. Personal care can be a combative experience, often aggressive behaviour is occurring, and they may have abnormal reflexes and involuntary tongue movements, which can make mouth care very difficult to deliver. Recommendations: integrate oral health care into the care plan, twice daily brushing, there's mouthwashes, dental review, make sure there's a lot of fluids, adequate sedation for dental work. Some nursing homes now have a dental chair in their nursing home, which I think is an advance, and geriatric dentistry is expanding. There are recommendations from the Commonwealth, and that's a website which you can go to, and there's an oral health assessment tool. And I think I'm coming to the end now. The last comorbidity I wanted to talk about is visual dysfunction. And this has great implications for you if you're working in falls and gait. Because changes in visual acuity and contrast sensitivity and visual field defects can be early symptoms of all dementias, well, most dementias. Alzheimer's disease and vascular. They can have problems with spatial and colour vision, blurred vision, reading, writing, depth perception. The biggest issue, thing that makes me most unpopular with patients, I usually get on pretty well with them, is when I have to tell them to stop driving. And vision, of course, is an important consideration here. They have difficulty locating visual objects, identifying people or objects, and they may have visual agnosia. They can see things, but they can't work out what it is. The famous book by Oliver Sacks, The Man Who Mistook His Wife for a Hat. He could see his wife, he could see the outline, but he couldn't process what he was seeing. And often we hear about this, about patients from their families who say they just seem to trip over the chair or not know it's a chair or a plate or whatever. Visual dysfunction also can lead to visual hallucinations, a syndrome called balance syndrome. In the Blue Mountains eye study, there was a significant association with impaired visual acuity and cognitive impairment. Age-related macular degeneration, really common in the elderly, at least 30%, have a higher rate of cognitive impairment. There's an increased incidence of glaucoma with dementia. And there are retinal changes now being used as a diagnostic test where you can see the amyloid in the arteries at the back of the eye. So the recommendations, be aware. A lot of these things, be aware that people with dementia, and remember half the people coming into hospitals, those who work there, are over 70, certainly at Prince of Wales where I work. And 30% of them will have cognitive impairment. We need to educate families about visual agnosia, good eye reviews, and to use spectacles. And there's an argument that Stephen proposes is that we shouldn't be using multifocals because that increases the risk of falls. Sorry, one last one. This is sleep disturbance. No, two last ones. How am I going for time? All right. So there's age-related changes in sleep in most older people. But in Alzheimer's, circadian rhythm gets disrupted. It's like the architecture gets all broken up. They might sleep 7, 8 hours in 24, but not when everybody else is sleeping. Might be 3 or 4 hours from 9 till 1 a.m., and then sleeps during the day. The body clock, the suprachiasmatic nuclei, have decreased cell numbers, and this is the centre that controls the circadian rhythm. In Lewy body dementia, it's particularly it may be the earliest symptom, is a disruption of REM sleep, and I'll come to that. So, up to half the people with dementia or their carers report sleep disturbance, and this increases as the dementia progresses. Another problem is sleep apnea, which is very common in the population, but more common with dementia. So we know that can impair cognition by itself, but the impaired cognition as part of the dementia can cause the sleep apnea as well, or lead to it. And just a word about Lewy body dementia. Lewy body dementia is a type of dementia associated with normal dementia, or usual dementia, I should say, but also with falls. Bradykinesia, slow movement, rigidity, not as much of the tremor. It's on the spectrum with Parkinson's. And one of the earliest features is loss of REM sleep, normal REM sleep. So what happens in REM sleep? When you have dreams, you can fly, you can have battles, you can have fights, you can do marvellous things. But a part of your body switches off the motor component so you don't act them out. You're actually paralysed while you're having these wonderful dreams. Now, if you lose that part of the brain that disconnects the motor part from the dreaming part, you can actually act these out. And there's some wonderful videos you can see of people with Lewy body in their sleep, beating, bashing. If you're sleeping next to that person, it can be quite dangerous. And people also have been able to videoed getting up, walking around, and so forth. So the part that paralyses people during their REM sleep is damaged, and they can act out, and this can be one of the earliest symptoms of Lewy body dementia. So recommendations for sleep: exercise during the day, adequate exposure, avoid daytime napping, sleep hygiene measures, about caffeine and so on. Sedatives, well, we know the difficulties there. And people have tried melatonin and bright light therapy. And I think this is the last one, Kim. This is urinary incontinence in dementia. People with dementia do get incontinent often doubly incontinent in the very late stages. They lose the cognitive ability to interpret the sensation of a full bladder. They lose motivation to inhibit the passage of urine. They can't plan how to get to the toilet. They may not be dexterous enough or quick enough on their feet to get to the toilet. They can't find the toilet. They can't undress and dress, and they may have visuospatial problems. There's heaps of reasons why people with dementia may get incontinent. It occurs earlier in certain sorts of dementia, vascular, Lewy body, frontotemporal. And there's a wonderful acronym in Sue's book, DRIP, DRIP. So if you look at the Ds, delirium and drugs, the Rs, retention and reduced mobility, these are the reasons. I, the infection, and we do routine UTIs whenever we think something's changed with a person, or impaction, like fecal impaction. And the P, polypharmacy and polyuria. Recommendations: assess and treat reversible causes, prompt voiding 2nd to 3rd hourly, pelvic floor exercises, absorbent pads, beware anticholinergic medications. You know, a man with prostate, you give him anticholinergic, he goes into retention. Catheterization, that's really a last resort. So let me conclude. In clinical practice, many conditions are associated with dementia and are unrecognised. It is important that these are identified and managed appropriately to improve the care of people with dementia and their quality of life. Here's the book, and here's a picture of Sue Curl. So you can download it. You have to pay for it from Cambridge University Press. And that's our website at the bottom, where you can get a copy of this talk. So it's dementiaresearch.org.au. Thank you very much.